anybody has any questions for the rest of our friends here, or anything that we haven't really touched upon that might be interesting to individuals.
Yeah, I had a question. So lymph node dissection.
Sure.
You mentioned earlier you had a case, low grade, did nephrourectomy. What is your selection criteria for lymph node dissection? Does everyone get one, or only certain high-grade patients, higher risk patients?
If you look at the guidelines, which I obviously have just reviewed them before we did all of this before the meeting, it says it's very particular on a patient that undergoes a nephrourectomy for low grade. It says physician or clinician may do a lymph node dissection, and then on somebody with high grade, it's clinician should do a lymph node dissection. So the guidelines are in our favor to do what you think is best at the time. My personal preference is that somebody with a bulky disease that I'm doing a nephrourectomy, it's bulky, low grade. Because of that risk of upgrading and upstaging, I will do a regional lymphadenectomy.
I completely agree. I completely agree. You also have to take into consideration the, atherosclerosis in the aorta and the vessels, and you have to just be, cognizant of that, certainly. But that being said, but I totally agree. High grade, bulky, low grade, if something that you think is at higher risk for upgrading, size is, one of those factors. So, yeah, totally agree.
And it's important to follow the template too, right? So depending on the location of the tumor, you want to make sure that you include the appropriate template for the lymph node dissection. So, it's one of those scenarios. If you don't do it, that's fine. But if you do it right.
Yeah, so, right. So renal pelvis proximal ureter on the right, paracaval on the left, para-aortic, and then, pelvic and mid, common.
Extended pelvic.
Absolutely. Yeah.
So I think that's important.
All right, great. One last question I was going to ask before we get away. So, Dr. Feldman, you have integrated UGM 101 from the very beginning in your practice, right? But I think one of the biggest challenges across the country is people want to integrate new things into their practice as they come out. But it is hard for a lot of people to do that. It's hard for academics to do it. It's hard for community practices to do that. So do you have any advice for somebody wanting to do, UGM 101 or do something new of getting into their practice from the get-go?
Yeah, I think you're right. It was hard, and it was one patient in particular that drove me to push it through because I needed to. That was the only option for this. It was really, that was really the only option, and it was early. It was right when it was approved. Convincing the pharmacy, getting your, staff, the department resources. It's hard, and then you don't always get everything right in terms of reimbursement and figuring all the pathways out. So, but once you to get that path of creating change and making changes with the pharmacy and all that, you do have that a little bit of experience that you can then make do other new things in the future, and yeah, just engaging, I think, as many people in your department or division that can help you push that process forward. But it's a lot of work. It is.
Sure. Anybody else have any advice on things like that as people are trying to do new things in their practice?
Well, I just want to comment that, because I probably shouldn't walk away without, I talked about neoadjuvant therapy before surgery, which has far less robust data, and what has the most robust data is adjuvant. So let's walk away and not talk about it. I think that all patients, that didn't receive neoadjuvant chemotherapy and then should have a discussion with the medical oncologist afterwards of whether or not they qualify based on the tumor size and node positivity of platinum-based chemotherapy, or at that point, adjuvant checkpoint with nivolumab based off of Checkmate 274. Okay. So those are important discussions.
Sure.
I agree. Yeah, I mean, I might just comment if we, in terms of who do I think about neoadjuvant in, right? So anyone who has high-grade disease, clearly invasive on imaging, absolutely, right? Any, adenopathy, obviously, so if you have adenopathy and you want to biopsy that and demonstrate if there's involved nodes, because that person needs systemic therapy first, right? So, and then somebody who has high-grade disease, and then, based on what you had said earlier, totally agree. If you think they're going to then be cisplatin ineligible after nephrourectomy, that person absolutely should be considered. The question I would have for you is, so if someone someone, has a nephroureterectomy, their GFRs, let's just say 40, they're cisplatin ineligible. What are you going to give them? Are you going to give them carbogem? Are you going to give them nivolumab? What are you going to give them?
I think that's a tough discussion that definitely, I don't think it's unified within the genitourinary community because we have data. If you look at the adjuvant data we have out in patients that were in this GFR category that could not get cisplatin, came and split it when we're going under in the 40 ranges. They gave gem carbo, and overall there is, in the updated data, there's a DFS and OS benefit. In Checkmate 274, where they got adjuvant nivolumab, there is currently a DFS benefit that looks pretty good, and I think eventually there's going to be, we'll get the OS, the final OS, and I'm hopeful that there's going to be an OS benefit. So now we basically have two options, and if you look at the subgroup analysis for both of them, they kind of both cross one. So they both have a little bit less for specifically upper tract urothelial. So they may be, there's a tendency to think maybe they don't work as well as they do for bladder. But again, subgroup analyses are not designed to tell you the overall picture. So you can use either one of them. And my experience is, I probably, all things being equal, will maybe lean towards gem carbo and then Nivo as an alternative. But there's whether or not they have autoimmune disease, whether or not some people don't want chemotherapy, and then moving to Nivo.
I think our medical oncologists would largely do the same.
Yeah.
It's not an easy question.
No.
I want to bring it back to the neoadjuvant chemo for a minute. I think one of the biggest challenges there is that we're not able to stage patients very well with imaging. Even just drawing from my experience, I did a nephroureterectomy a few years ago, or a couple years ago. It was a young patient with what looked like probably T3 disease. There was some fat stranding. It was pretty bulky tumor. No large lymph nodes. Everybody felt like she needed neoadjuvant chemotherapy. And despite a lot of discussion with her medical oncologist, another surgeon, and myself, she absolutely refused. So I took the kidney out, and it was T2 and 0. So we're not able to, I think, stage people very, very well, especially T staging using traditional imaging. So that is definitely a challenge when it comes to patient selection. And then another point is not everyone responds to neoadjuvant chemotherapy. So I presented a study earlier today where we used a multi-institutional database from 7 large tertiary care centers, and only about 25% of patients had some sort of response to neoadjuvant chemo. And there was a huge difference in terms of survival outcomes between responders and non-responders, but not everyone responds. So.
And what was I guess I would say, what percentage, there's response, but what percentage progressed through chemotherapy, through neoadjuvant chemotherapy?
That's a good question. I don't know that we were able to tease that out in the database because everyone underwent.
Because you're going to have a percentage that don't respond to adjuvant also, right? There's just a percentage that don't respond.
Yeah.
The question is, are you missing, right? You're not necessarily treating the renal pelvis or kidney so much. You're treating what you think cells have already maybe, metastasized, right? So, so that would be a question I would ask is, who actually got worse through neoadjuvant chemotherapy? Because if that number's really low, then that does argue, in my opinion, for for neoadjuvant.
Yeah.
But I agree, you have to, and then, but if you treat everybody with high-grade disease, you're going to overtreat a lot of people.
Absolutely.
Yeah.
And that's why I think you have to really think about it, and it is a nuanced approach.
Yeah.
Well, I think you're right, right? And multiple people have already said this, that when it's easy,
Yeah.
right? When you see the big
yeah.
tumor, when
Yeah.
you see like some questionable nodes or whatever, that's a slam dunk. Everybody knows that person needs neoadjuvant. But it's when you have a 2 or 3 centimeter tumor and it looks like it's just kind of hanging out in the renal pelvis, and it does come back and the cytology is high grade, the pathology is high grade, and that's when you're hemming and hawing saying, is this really T2 disease, or what is the risk that I need some systemic treatment on this person up front, right? And that really isn't even a hard question unless you think their GFR is going to be so terrible post-op that they're not going to be able to receive adjuvant therapy.
Right.
Because that person, you could forego neoadjuvant and say give them adjuvant unless their GFR is going to be bad, right?
And that patient with T2 and 0, would you offer adjuvant if they're cisplatin eligible?
They're cisplatin, and they received no neoadjuvant.
Correct.
No,
For
not
T2
for
and
T2. No, and T2. I would have given it. And that, no, and I've been in those situations before where it was actually it looks like a whopping tumor, and then I say I would recommend neoadjuvant chemotherapy. They say no, and then it comes out, and then I've seen a T1 out of that, and I was flabbergasted. I think those cases are out there, and at some point it's going to be a combination of imaging. Who knows? AI computers trying to figure it out. Urine-based biomarkers, whether it be the cell-free DNA.
Sure.
And I think at some point we'll get our own like upper tract, some BI-RADS or VI-RADS.
Yeah, but I think that speaks to why in somebody who's going to have a adequate GFR after surgery, then it's very, very reasonable to just go forward with surgery.
Sure.
Yeah.
That's probably preferred.
Thank you so much to the panel for being here today. This was so much fun learning from everybody for upper tract urothelial carcinoma. Once again, this is GU Oncology now with AUA 2024.